Thank you all. So this is the end of the day, right? That means I have to be really exciting because you're all very tired, right? And ready for your Saturday evening plans. Well, me too. Believe it or not, even being an old man and a dean and a professor, I like to have fun sometimes too on Saturday evenings. But we'll start the fun now. So I'm going to talk to you about a number of things, and you've probably heard different things about pharmacy earlier in the day, about different opportunities and how the profession's shaping and evolving. And you probably heard the SB 493 and a couple of other things like that. So I'm going to talk about those things too, but couch it in a little bit different perspective, because I want to talk to you about public health. No, I'm not talking about a public health program. I'm talking about a pharmacy program. And I'm talking to you about public health and where pharmacy stands in the delivery of public health and why that's so important and what my institution does, CNU COP, does to really prepare you to engage in a lifelong trek of service in the auspices of public health. In doing so, I'm going to start out with a little bit of history about pharmacy, because that's absolutely necessary to know where we've been, to know where we are now, and to know where we're going. But notice I say a brief history, because how many of you just really, really love history? Okay, that's 3 more than I would have anticipated. Because usually people thinking about majoring in pharmacy or medicine or nursing are not exactly history buffs. You're more inclined towards science and math and chemistry. So that's why whenever I give a lecture on history, and I like history myself, because a little bit of background about me, I am a pharmacist, but my Ph.D. is actually in something called pharmacy administration. So you've heard of pharmacology, pharmaceutics, pharmacotherapeutics, biochemistry, but there's a part of it that's pharmacy management, pharmacy law, pharmacy ethics, pharmacy communication, patient behavior, patient sociology of illness, and so forth and so on. And that's my area, which kind of includes history. So I like a little bit of history myself, even in spite of being a pharmacist. So, but nonetheless, I know that people do not like really, really long, boring history lessons. So we're going to cover several thousand years in perhaps the next 5 minutes. In ancient times, not ancient times, that could mean a lot of things. It could mean a couple of hundred years ago. It could mean, several thousand years ago. So pharmacists in some form have always been around. They weren't necessarily called pharmacists, and it wasn't necessarily an occupation in and of itself, and it certainly wasn't a profession. But we've always looked toward pharmacists as healers, those people who are able to leverage some knowledge in chemistry, in a little bit of knowledge about anatomy, and a little bit of knowledge about pharmacognosy or deriving medical benefit from plant substances or animal substances, whether it might be hair, cell cultures, tissues, whatever the case might be. So we've relied on what we now call pharmacists. It could have been witch doctors, it could have been chemists, it could have been in Latin American cultures, brujas, which certainly still exist today. Now, we'll skip forward now a few thousand years. See, I told you this is a brief history lesson. So we go now to early colonial U.S., and not that much differently necessarily than what was going on in pharmacy around the rest of the world either, for that matter, in the 1700s, late 1600s, 1800s, so forth and so on. So we'll concentrate on pre-colonial U.S. So pharmacy as a trade was born under apprenticeship. You didn't go to college necessarily to be a pharmacist. Now, I might date myself a little bit. How many of you have seen the show Little House on the Prairie? Some have. If you haven't seen it, you've kind of heard of it, kind of know what it's about a little bit, kind of life in the 1800s out on the prairie there. And even though it's dramatized, obviously, for television, just as any other show is, Among the things they would show people learning jobs under apprentices, like blacksmith, silversmith, so forth. You basically worked with a senior peer colleague for years, and then after a while, you became a blacksmith yourself. Well, the same thing was the case with pharmacy. Now, another thing that they would depict on Little House on the Prairie, you would see every once in a while somebody, every few episodes and every few weeks in a little town, somebody would come in a wagon and they were selling this magical elixir. And it was elixir that was used for cough, for cold, for measles, for mumps, for pain, for anything and everything, all in this magic elixir. And you know what that elixir usually was? Perhaps. It had water in it. A lot of this. A lot of alcohol. It was basically a lot of ethyl alcohol with some stuff. And the stuff was at best neutral for your health, if not deleterious to your health. Efficacious? Forget it. Safety? Let's just hope. That's the kind of stuff. And that really was sort of the way things, that's the way healthcare went back in those days. Pharmacists were people who were there to safeguard the public against these things, to make their own homemade concoctions that they weren't trying to sell statewide, territory-wide, nationwide. So they were there to safeguard the public. And thus, we began to see, after a lot of criticism of these medicinal peddlers, we began to see the first pharmacy schools and also the first professional pharmacy associations, the American Pharmacists Association in the 1850s, and we also saw the first pharmacy school, USP, University of Sciences in Philadelphia, also around 1860 or so. So thus, we began to see the origination of a profession as opposed to an occupation. Then this was really moved forward by the Flexner Report. Who's heard of the Flexner Report? Can you tell me a little bit about the Flexner Report?
It was a study that has standardized the medical care given at the time.
Very good. Abraham Flexner was commissioned by the government, actually, to really take a hard look and ultimately form this huge committee and draft this report. It was released in 1910. And at the time, the report was geared primarily toward medicine and medical practice. And it said, the Flexner Report stated that there was no standards, there was no accreditation, medical schools varied widely from one to another. It was after the Flexner Report, which ultimately paved the way for what we now call today allopathic medicine, an MD, a medical doctorate degree. Because before that time, there was all different types of medicine being practiced without these sorts of standards. Now, the Flexner Report was aimed at medicine, but the reverberations were felt throughout the other healthcare professions, such as pharmacy, nursing, so forth and so on. So we began to see more and more pharmacy schools. We began to see more and more standardization of their curricula. We began to see some accreditation standards for pharmacy schools back after, in the next decade or two after the Flexner Report. Now, you see, I told you the history lesson was pretty brief. Now we're skipping all the way into the middle part of the 20th century, okay? So pharmacists began to be educated. They began to get 4-year degrees at the time, okay? And that's 4-year degrees counting everything, not like 4-year post-bac like we have now. But the pharmacist's role began to be squeezed a little bit from prefabrication of drug products. And what is prefabrication? He asks, looking for an answer. Yes. pre-made, like a prefabricated home is when it's already made. They haul it like a trailer and they just plop it down somewhere. Well, it was not until the 50s or 60s, which may sound to you like ancient history, but in the scope of time is really not long at all. It wasn't until the 1950s and 60s and even 70s before we saw massive prefabrication of drug products coming in capsules, syrups, and so forth and so on. Before that, the pharmacists had to do a lot of compounding, right? So then the pharmacist's role began to be squeezed a little bit. Our own code of ethics at the time stated that we shouldn't really talk to patients about the drug. That's what our code of ethics actually stated back in 1956. Then, all the medicines that we were compounding, or used to be compounding, were now being prefabricated. Pharmacists became the proverbial, and I hate this term, the counters and liquors and stickers, so to speak. We started to rebound from that. Pharmacy education began to respond by making the whole curriculum very, very much more scientific than it was before. Really grounded in earth sciences, in anatomy, in physical sciences, in chemistry, so that we can begin to see advances profession-wide, not just among small scientific laboratories, that the whole profession would begin to make strides. And thus was born the whole concept of clinical pharmacy and pharmacotherapeutics. Now, all this time, even while pharmacists' roles were relatively marginalized, for maybe 3 or 4 decades or so, we actually maintained a pretty good image out in the community. Always being trustworthy, always being looked upon, but not necessarily with the same type of view that we give to, say, other types of healthcare professionals. Pharmacists were viewed more as business persons who just happened to be very ethical, who happened to be very upstanding, and who also happened to be very knowledgeable and dispensing drug products, but they weren't necessarily viewed as the healers that they used to be back before the prefabrication of drug products. Now, in the last 20 years or so, and I'm sure you've heard today how much the pharmacy profession has changed, how much strides that we've made in the last 20 years, and that is indeed the case. We have become part of an interdisciplinary healthcare team, which I'll expound upon in just a moment. We've maintained that level of trustworthiness with the public, and we still remain the most accessible healthcare practitioner. You don't schedule appointments to see the pharmacist, by and large. We're often the entry point into the healthcare system for many patients. Certainly not acute trauma patients suffering from an emergency accident or something of that nature. But for many, that this is hurting me, or what's this on my skin, or this medication's not working. I've been suffering from migraines. Can you help with this? We are often the people that the patient sees first in the healthcare system. So, but we haven't always leveraged that accessibility. We haven't always leveraged that trustworthiness, which is what we've begun to do finally the last 10 or 20 years, and what the future is shaping up for us with healthcare reform, with SB 493, and some of the other things I'll fold more into this presentation in just a moment. So we're at the cusp of both individual and population-based care, and I'll talk more about that in a moment, and we're part of an interdisciplinary healthcare team. Now, what does that mean when I say that we're part of an interdisciplinary healthcare team? Without looking at the slide. Our nation is built upon relatively fragmented care. You see the physician, you see the pharmacist, you see the nurse. They haven't always been working that well together. An interdisciplinary healthcare team means that the healthcare professionals put the ego aside and the patient comes first. And they share knowledge with one another. They empathize with one another for the benefit of the patient. I'll give you an example that I gave the last group that I talked to a few moments ago. When I was at before I came to Cal Northstate 16 months ago, I was at the University of Oklahoma, and it was part of an academic health center, all under the same auspices in the same campus. We had medicine, we had pharmacy, we had nursing, we had dentistry, we had veterinarian program, we had social work, and all these kinds of things. One of the physicians that the pharmacy school worked very closely with is one of the premier migraine headache specialists in the country. And Dr. Wise was his name, literally Dr. Wise. And Dr. Wise had a team. He had at least one, if not two, of our clinical pharmacy faculty. He had a couple of his own medical residents. He had a nurse or two. So after the previous patient visit and before he went into the next patient's examination room, he sat with the team. And all of this I'm about to tell you happened within a span of just 2 or 3 minutes. So he would have the resident read the history of that patient and what was going on with that patient at that time and why that patient was here. And usually if they were there to see Dr. Wise, they were a recalcitrant patient who's been probably seen 10 or 12 other doctors about their migraine and just haven't been able to get it resolved. So the medical resident reads to Dr. Wise what's going on with that patient's chart and so forth and what's happened in the last 2 months. So Dr. Wise listens to that and immediately begins to start firing questions at people. Starts firing questions at our clinical pharmacists. Okay, so tell me why that when I put this patient on these 2 medications 2 months ago, it worked for 2 weeks, and then they started getting rebound headache and so forth and so on, and why so tell me that. The pharmacist would respond right there. So he then to turn to the nurse and tell me why in the last 3 weeks this patient's complaining of this and that, the other, nausea and so forth, and so the nurse would respond. Then he'd say, you know what, this reminds me of an article I read somewhere in cephalgia or headache in the last 3 or 4 months. And so his resident would pull that up on the computer. And so then they would brainstorm for about 3 or 4 minutes. And all this would happen just lightning quick. And then they were ready to go in to see Mrs. Jones. That's an example of interdisciplinary healthcare. And that's what we're beginning to see more and more of. It's not everywhere, but it's a growing expectation. The Affordable Care Act and many other state healthcare reform measures actually require that. So it stresses preventive health, self-care, and empowerment. Empowerment's really huge. Patient empowerment means better health outcomes, unequivocally. Not the passive patient, not the passive aggression patient, but the empowered, assertive patient who has bought into their own health care and understands that, you know what, I can go to the doctor and the physician can prescribe medication. But if I don't take the medication, and if I don't listen to what the pharmacist tells me about how to take that medication and when not to and what not to take with it and so forth and so on, and if I don't do this, and if I don't get enough rest, and if I eat these wrong foods, and if I don't exercise, if I don't do this, then I can go to the physician every 3 days, and it's not going to do me a darn bit of good. So patients are becoming increasingly empowered, and that means, in and of itself, more autonomy, more activity, more responsibility for pharmacists. Because we are the entree, as I mentioned, into the public health care system, and we oversee many things, including the patient's prescription medications and also over-the-counter medications. Who can tell me something unique about over-the-counter medications? What are over-the-counter medications? They're medications you don't need a prescription for. But are you aware that probably nearly 100% of them were prescription at one time? Nearly every over-the-counter medication was at one time prescription only. After a long number of years that it was relatively safe compared to others, it got put over the counter. Even things like you take for allergies, let's say antihistamines. What does antihistamine mean? It means it blocks histamine. Histamine is a neurotransmitter in your body. So when you block histamine, you block histaminic responses. That enables you to dry up when you have allergies. That reduces the triggers you have to certain sensitivities. For some people, it's certain food substances, pollen, weeds, trees, different sorts of things. So it works by blocking the histaminic response, which is generally a good thing. But histamine exists for a reason, right? So when you block histamine, that could have negative effects as well. Histamine exists in our bodies actually for a lot of good causes. So the stuff that you buy over the counter that's an antihistamine versus the prescription antihistamine, they're both antihistamines. So they both work by blocking histamine. And when you block histamine, there are inherently good effects and deleterious effects. Oftentimes, the things over the counter have just been on the market longer and often sold at a lower strength. But when you block histamine, when you block dopamine, when you block serotonin, or when you potentiate any of those things, whether it's over the counter or prescription, it's still working the same way. So you have an opportunity for negative repercussions and drug interactions if these things aren't taken correctly. And guess what? There's been hundreds of things go over the counter just in the last few years, and there's going to be a whole lot more. As we further scrutinize healthcare costs, and as drugs have been on the market longer and have proven a little bit safer than maybe some of their other counterparts, there's going to be more, not fewer drugs go over the counter. So this is a huge, huge role that we play in safeguarding public health. Now, I put a definition there for you. I'm not into reading definitions, but public health is basically a societal endeavor and includes primary, secondary, and tertiary public health. Primary is complete prevention. It's like fluoridation of water. But it's also providing education. That can be a primary source of public health. Secondary, things like screening, early diagnostics procedures. And tertiary is basically what we're accustomed to is what healthcare is. It's just taking care acutely of the sick. So public health is more and more relying on primary health care because we want to keep people well. We don't want them to have to get sick. We want to keep them from getting sick. So pharmacists are increasingly involved in public health. In fact, I would argue that we are the public health guardians. We are the public health sentries. We make individual and population-based care decisions. We make individual-based decisions all day, every day. Patient comes, they have prescriptions, we're determining the appropriateness of the medication, or even in the hospital setting where a patient might be on 12, 15, 18 medications at one time, the pharmacist is making sure that all of these different prescriptions make sense and they're cogent and that there's no interactions and so forth. So those are individual-based decisions. Now, how many of you know what a formulary is? What's formulary?
It's the drugs that are covered by insurance.
So drugs, it's a list of drugs that are covered. Now, of course, there is considerations for cost, right? But there's also other considerations such as effectiveness, safety, and things of that nature. Now, who often informs the development of a formulary? P&T committee, and who's some of the main people on the P&T committee? Pharmacists, okay? And that's a population-based decision, okay? So what do I mean by population versus individual-based decision? Well, if you're a pharmacist and you inform a formulary decision, let's say there's 1 million people that are covered by this particular insurance plan. Let's say 30,000 of them are diabetics. Well, you've made a decision that, in essence, by making a decision about this particular medication, or which to cover or not to cover, or to cover with some sort of caveats or protocol or things of that nature, you've, in essence, made a decision that affects 30,000 people. That's what we call population-based decisions, population-based care. So pharmacists are involved in that, but they're also involved in screenings, in education, in triage, immunizations. Our students are probably, at my university, are probably going to do several thousand immunizations this weekend alone. At 2 health fairs we're conducting, and another several thousand in a couple of weeks in our big health fair. So we're really involved in public health. And we also report medication events. You know, you've heard of drugs getting recalled, right? Just because they make it on the market, even though they've been tested for 10 or 12 years, sometimes they prove to be unsafe after they've been out in the public. You know, some things have been recalled, like Vioxx and Celebrex and so forth, but there's been many others. Well, pharmacists and physicians too, they call their local health departments when they hear about an adverse drug reaction. The local health departments then contact the Centers for Disease Control, who shares that information with the FDA. So that's another example of us being part of a public health web or public health system. Now, all that said, and all the opportunity that lies before us, which I'll talk about in just a moment, pharmacists are still the medication experts. Now, you noticed in the beginning of my talk, I was giving you that brief history of pharmacy, and we talked about how pharmacy wasn't yet, hardly yet an occupation, let alone profession. Well, it's actually been debated, actually been studied, how an occupation grows and matures into a profession. They engage in full-time practice. We established university-based standard curricula and form professional associations. We band together, we agitate politically to win support. We form these associations, and we advance scientific knowledge. It might be in pharmacotherapeutics, it might be in chemistry, it might be in pharmacy practice, but we advance knowledge. We have a unique code of ethics, we have a formal code of ethics. But that knowledge base is critical. What would happen to a profession if it didn't have a unique knowledge base? Anybody can do it. Why would there be such a thing as a pharmacist? Why would there be such a thing? Why would there be a demand for them? Why would we license them? Why would we pay them 6 figures? Why would we do any of that? If they don't have anything unique to share, why would we do that? Now, there's certain things we do share. There's some basic pharmacology, some basic therapeutics, some anatomy, physiology. We share that with nursing. We share that with medicine. We share that even with certain types of technicians and so forth and so on. But nobody knows the medication, the drug, like we do. Its physiochemical properties, its drug structure, its structure-activity relationship. Those form the basis of why, say, this antihistamine reacts with this non-steroidal inflammatory drug. It's not like magic. You know, there's biochemistry, there's anatomy things, there's considerations going on there. And that is our unique knowledge base. What happened in the latter part of the 20th century, when I was giving you that brief history, is that we were failing to some degree to leverage that unique knowledge base into something that could advance the profession, advance ourselves, and really advance patients and patient care. We weren't necessarily leveraging those things. So now we leverage this knowledge and we apply it. But we also have to have other types of skills. Now, picture a clinician. It could be a pharmacist, but it could be a nurse or a physician. Picture a clinician who's a very poor time manager, always in crisis mode, always falling behind, very poor communication skills, develops very poor rapport with patients. How good can they be? How can a pharmacist possibly be good if they're always putting out fires? If they don't have time to spend with the patient? They can have every drug structure in humankind memorized in their head. How good a pharmacist could they possibly be? They couldn't. They couldn't. So our curriculum, and many pharmacy curricula, really try to take this basic science knowledge about the drug, but make sure we leverage that with knowledge of ethics, law, communication, sociology, developing patient rapport. Those are absolutely critical. That's where my college comes in, and I'd like to talk about it for just a little bit. We do have, like many other pharmacy schools, a foundation in biomedical sciences and pharmacotherapeutics. How many of you have heard of team-based learning? Oh, good. So somebody can tell me about it. Who can tell me about team-based learning?
You're given a set amount of readings, maybe perhaps readings to do, and then you do all that at home, you come into the classroom, you get together and you discuss and work on projects with that knowledge.
That's good. And that's kind of the crux. Our whole curriculum is team-based learning. We're one of 2 programs in the nation who utilize team-based learning throughout its entire curriculum. When you come at CNU, you won't see auditoriums like this. Not that there's anything wrong with auditoriums, but you won't see any. You won't see any desks and seats as you normally would. You see tables, L-shaped tables, students sitting all around the tables. They've been given an assignment to prepare beforehand. Right when they come into class, their individual readiness is assessed based upon those readings or problems or whatever they might have been assigned. And since they haven't necessarily had it in class, it's going to be a little bit of a struggle. And then the team gets to work on that same, maybe a set of 5 questions, maybe a set of 10 questions, maybe problem, whatever the case might be. Now, you might have a team of 5 people. And out of those 10 questions, you might have known 5 out of those 10 yourself. You might have known 3 of the 5 that he knew, but knew 3 others that he didn't know. And then somebody else will likewise know one that neither of you knew. So the team then gets assessed. And not surprisingly, out of the 10 questions that you might have gotten 5 out of, the team maybe gets 9, maybe gets 10. Your grade is accounted for by both your individual readiness and your team readiness. Then, now, all of this is done through, the faculty member is utilizing some sort of active strategy like gaming strategy or maybe the clickers, what have you. So the professor then is able to gauge right away what concepts were lost on the class. Okay, there might have been 5 or 6 major concepts that were going to be covered in that 2 or 3 hour class that day. Professor sees, okay, seems like from the individual and team-based assessments, because they're right there, they're done real time using technology. Well, the students get this, they get this, they get this, they didn't get this, they didn't get this. So then they're prepared to perform a mini lecture, if you will. And that's why the faculty has to be so prepared. It's a lot more difficult doing it this way for our faculty than it is just to come with a canned talk, because they have to be extemporaneous. They have to be, now, of course, you know, anytime you've taught something several times, it is always easier. You have history on your side. You kind of know the trends. But you have to be prepared in the event that the class did not grasp something that you thought or hoped that they would from the readings. And they might have grasped something better than you thought and something else not as good as you thought, not as well as you thought. So you have to be ready for that. So then there's the mini lecture, and then there's the application exercises. Like, for example, I told you I teach pharmacy, well, before I became a full-time administrator, when I was a full-time faculty member, I would teach things like pharmacy management as opposed to, say, pharmacology or therapeutics. So for me, a team-based learning exercise might be to give the class and each of their teams, say, a balance sheet or an income statement from Joe's Pharmacy. Say, here's Joe's Pharmacy. Joe's Pharmacy's losing money. Joe might have to close his doors. So here's Joe's assets, here's Joe's liabilities, here's Joe's owner's equity, here's was his sales last year, here's was Joe's industry averages sales, here's the amount that Joe has inventoried, here's Joe's cost of goods sold, all these kinds of things. And the application might be, okay, now you tell me what Joe should do. Should Joe close? Should Joe sell his pharmacy? Should Joe maybe just change his credit policies? Should Joe change his store hours? Should Joe cut back on technicians? Should Joe think about diversifying his revenue streams and doing more MTM services and less dispensing? You tell me what Joe should do based upon the financial information I just gave you. And so the class then works on that as a team. It's an absolutely terrific thing. So we've seen terrific outcomes from that. We've graduated just 2 classes. So we're at that stage, we're not brand new, we're not starting from scratch, but we haven't been around forever and a day either. We're still very flexible, we're still very malleable, but now we have a little bit of history on our side. Our classes have performed extraordinarily well on the licensure examinations. But you know what? They perform pretty well in a lot of schools' examinations. What we have heard a lot of is how our pharmacy students, because of this curriculum that's not passive, our students are really prepared to engage. They're great communicators. They're great leaders. We've had a pharmacist, we've had a student who graduated this past year. He was the national president of the Student National Pharmacists Association. That from a new school, mind you. We have several students who are currently holding positions in the California Pharmacists Association and national associations, national committee chairs. I became dean just 16 months ago. And I really encourage the students to do even more of engaging the community and to be more autonomous. Because I used to get these emails, hey, Dean Desselle, I met the sheriff, and is it all right if I... You don't need to email me with that. Go. We forged so many collaborations. You might have seen an article in the SAC-B not terribly long ago. It showed an article co-authored by me and the sheriff's office from Sacramento County. We have a program called Generation RX to stem the tide of prescription drug abuse, which has now become more problematic than illicit substances like heroin and cocaine. We have relationships with Sac State, we have relationships with law enforcement, we have relationships with food vendors, we have relationships with you name it, because we're out there, we're engaged with the community. We're doing what I think an educational institution, a contemporary educational institution is doing. We're taking responsibility, we're putting things in our own hands. Just this last few weeks, we've initiated a new PharmD MBA program with Sac State. Our first cohort of students are entering that this March. We were cited by our accreditors as a national best practice nationwide for our interprofessional education program with Sac State School of Nursing. We got accredited a residency program with Sutter Health. and we're launching 2 more residency programs in community pharmacy in conjunction with CVS and Rite Aid. We are starting a master's degree program effective maybe 2014, maybe 2015. We also started a postdoctoral scientific fellow program. Our first fellow started in July 1 this past year. So we're growing, we're engaged in the community. Of course, this is American Pharmacist Month. You've heard about SB 493 passing, which will enhance the scope of practice of pharmacists. It recognizes us formally and officially as health educators so that we could actually code and bill for the services that we do. This is designed to ameliorate the shortage of primary care physicians that exists in this state. And that for all the good things that the Affordable Care Act might do, some of the things that, just like any piece of legislation, has some negative effects as well. It's probably going to further exacerbate or make worse this shortage of physicians. That's one of the reasons why that this bill passed. CNU held a huge part in SB 493. I'm not going to say we're solely responsible, of course not. But look at the California Pharmacists Association webpage. You'll see a big, huge group of students there with some legislators. That's CNU students. We take advantage of the fact that we're right here in Sacramento. We're the only pharmacy school in Sacramento, and we take advantage of the fact that we're right by the Capitol. In fact, Dr. Richard Pan, he's an assemblyman. And as the name suggests, he's a physician. Now, do you think most physicians were in favor of SB 493? No, we don't. We still have even though we have interdisciplinary health care, we have turf wars. Physicians don't want pharmacists doing this and that and the other, and pharmacists don't want nurses doing this and that and the other. Dr. Richard Pan came out with CNU students all the time to health fairs in his local district, out around Elk Grove and South Sac area. Richard Pan's a physician and became a chief advocate for SB 493 because he was out there with CNU students conducting these health fairs. And he was also chair of the health committee of the assembly. So needless to say, we played a big part in that. California Society of Health System Pharmacists got a grant of $500,000 with Covered California. And so we have already been working with them. They're looking for 100 educators to kind of educate the educator in helping patients and so forth. So about 15 or 20 of our faculty have already signed up. I routinely meet with their director. In fact, I met with their director, Dawn Benton, just this past week. Because I'm on various boards like the Leukemia Society and the Diabetes Association. I'm working with her. Actually, she's running for Woman of the Year for Leukemia Society. I'm the one that nominated her. So we're out there. We're engaging the community. We're engaging the entire world. Just this past few months, I used my connections with McGraw-Hill to sign 3 book deals for our faculty, publishing scholarly books. I just completed a Fulbright Scholar application myself, and there's 3 universities in Australia and 1 in New Zealand that want to host me for about 2 months next year. So we're out there doing all sorts of things. October 26th is our big health fair. We had it on campus last year. It's growing. We couldn't have it on campus anymore because we want to serve more people, so it's actually going to be at the Lowe's on Zinfandel Drive right by our campus in Rancho Cordova. And so just lots of great and exciting things happening with our college, just tremendous amount of growth. And with that, I would love to take any questions that you have. You're not allowed to leave unless I get 2 questions. I'll run upstairs and physically block you from leaving.
I guess what specifically do you think your school is doing that's unique in the community? Like for the community?
I think the accreditors that visited us this past spring, a lot of pharmacy schools are understanding the need for public health. I think we have codified it to a greater extent. I mean, there's a lot of schools doing some nice things. I know I have really good friendships with some faculty at USC, And I know they have, you know, that's a whole different kind of program, obviously. They have, it's a huge program. They have grant writers, and they've gotten grants to set up these clinics that serve underserved patients in some of the more at-risk neighborhoods in Los Angeles. So they're doing some great things. I think a thing that makes us, not say unique, but at least very poised to be so engaged in the community is that we stress it so much in our co-curricular outcomes. You know, we have a curriculum and we have a co-curriculum. We have 18 student organizations, and all 18 are active. And I say that with the utmost sincerity and candor. The last few schools I've been at, there were 12, 15 pharmacy organizations, maybe 4 or 5 of them were active. So our students have really, so the thing is, we emphasize this when students come to interview with us. We tell them about our public health orientation. We look for it in our students. And so I think one of the reasons that we've been so, and we're looking for it when we faculty. You know, I've been there just 16 months, and that was a public health orientation before I was there, to be sure. But I've kind of really refocused that since I've been there in the last 16 months. And so when we interview faculty, when we interview prospective students, we make sure and communicate our message of public health. And so we only want people who buy into that mission. We changed our mission and vision, or we changed our vision statement just last year. And so we make sure that everyone buys into that appropriately. So that's really, I don't know if it's, you call it a difference, I might call it a difference, it's just the buy-in institution-wide, not a buy-in of 3 or 4 people. Because you have buy-in from a few people everywhere. There's not a single pharmacy school that doesn't have buy-in for engagement in public health among at least a few faculty. There's not a single one. I think one difference that we have is that we breathe it from head to toe. And we make sure, and we don't get anybody in unless they buy into it as well. All right, I said 2. We've got to have at least one more. Come on, my wife is waiting for me. We want to go to Second Saturday in Midtown, have a little dinner, you know, but that can't happen until I have another question.
What got you interested in pharmacy?
You know what? So I was originally from a small town of 400 people in southern Louisiana. My mom's best friend was a pharmacist at the little town next over. And she used to take me over there, and I used to talk with him. And even as a little kid, I would be behind the counter. And so I kind of knew. But then, you know, as I got older and began to explore other options and so forth, I still knew that I was very inclined to be toward medicine or pharmacy or something of that nature. And I took a tour of University of Louisiana Monroe, where I went to college and got my graduate degree, and fell in love with the place, fell in love with the pharmacy program. And even though I was leaning to pharmacy over medicine at the time, you know, it was still a little bit of debate. And then when I went to Louisiana Monroe, I just fell in love with the campus and the pharmacy program and so forth, and never looked back after that. I was always fascinated how 200 milligrams of something, which is not a lot, fractions of an ounce of something can change your whole body, or kill you, or heal you. Always fascinated with that. Still am, even though I'm a social scientist now. My Ph.D. is actually in the administrative sciences, as I suggested before, but I'm still fascinated with how sometimes even 0.1 milligram of something can change the way your whole body operates. Anyone else? How are we doing on time here? Oh, looks like we're about out of time anyway, but it looks like we're done, but I will be more than happy to take any questions that you may not have wanted to ask. I'll hang around for a few minutes, and really appreciate you coming out to hear me this evening, and appreciate you staying out the whole day, and hopefully you enjoyed hearing a little bit, one more presentation about pharmacy and seeing you today. Thank you.